Most people think constipation is just a matter of not eating enough fibers or drinking enough water. But in my clinic, I often see patients who are doing everything right. The high fiber diet, the 2 liters of water a day, the daily exercise, and they are still struggling. The reality is that chronic constipation is rarely just a lifestyle issue. It's often a more complex problem of motility or physics that requires a more sophisticated approach than just buying a bottle of pear juice. Today, I want to move past the basic advice and look at the unusual causes of constipation, how we actually prevent it, and the advanced treatments we use when standard laxatives fail. In clinical practice, we look at constipation through 2 lenses. Number 1, slow transit, where the bowel moves like a slow-moving traffic jam. And number 2, outlet obstruction. That's when the queue is moving fine, but the exit gate won't open. The second category is where we find one of the most common, unusual causes, that is pelvic floor dyssynergia. This is a problem of coordination where instead of relaxing the muscles to allow a bowel movement, your body subconsciously tightens them. You can take all the laxatives in the world, but if the exit is physically braced shut, you just won't find relief. This is why I often refer patients for anorectal manometry, which is a specialized test to see how those muscles are actually behaving. We also have to look at the metabolic and neurological drivers. Things like an underactive thyroid or high calcium levels can effectively quieten the nerves in your gut. Even common medications for blood pressure like calcium channel blockers or iron supplements can be the hidden culprits. If your constipation started around the same time as a new medication, that's a conversation we need to have. When it comes to prevention, we need to talk about the gastrocolic reflex. Your bowel is most active about 20 to 30 minutes after a meal, particularly breakfast. Many people ignore that first morning urge because they're rushing to work or the kids are demanding attention. If you consistently ignore that signal, your rectum can become hypersensitive. It stops sending signals and the stool sits there, becoming harder and more difficult to pass. Prevention isn't just about what you eat, it's also about honoring your body's natural timing and using a footstool to put your anatomy in the correct squatting position. Finally, let's talk treatment. If over-the-counter options aren't working, we move into the realm of secretagogues, or medications that actually draw water to the bowel to soften the stool and stimulate movement. In Australia, we have specific medications like prucalopride for those who haven't responded to standard laxatives. For those with pelvic floor issues, the treatment isn't a pill at all. It's biofeedback therapy. That's where a specialized physiotherapist retrains your muscles to work in harmony. The most important thing I tell my patients is that long-term laxative use, when managed correctly, isn't addictive and won't ruin your bowel. What ruins your quality of life is the bloating, the pain, and lethargy that comes with chronic backup. So if you've been struggling for more than 3 months, it's time to move beyond the pharmacy aisle and get a formal motility assessment.